So, picking up where we left off on class the other day, we're going to talk about hydrocephalus first, and this is where there is a production of cerebrospinal fluid that's greater than how fast your body can absorb it. So the production of CSF is greater than the absorption of CSF, and this equals to the accumulation of CSF in the ventricular system, which then leads to increase in intracranial pressure, ICPs, and dilating ventricles. So just looking here, you can see that this baby on the left has normal production and absorption of CSF. There's no accumulation of CSF here in the ventricles, so their ICPs and everything is fine. On the right-hand side, you can see that this is hydrocephalus. The body's not able to absorb the CSF, so it's just chilling out here in the ventricles. It gets larger and puts pressure on the brain, dilates the ventricles, pressure on the brain, which is going to increase your ICPs. So just to kind of give you some lay of the land here as far as your ventricles are concerned, you have two lateral ventricles. So you have two lateral ventricles, and then you have a foramen here. You can see there's a side view here as well, where CSF flows from the lateral ventricles into the third ventricle. And then from the third ventricle, you have your cerebral aqueduct, which is also called the aqueduct of Sylvis, which is where a lot of obstructive hydrocephalus comes from because there's an obstruction in between the ventricles. So from the third ventricle, cerebral aqueduct or aqueduct of Sylvis, the CSF will flow into the fourth ventricle here, and then to the central canal, which this next slide I'm going to show you more of the flow of CSF. And I don't think you guys have this in your initial PowerPoint, so I'll be sure to add these slides with my notes of how the flow goes. So the actual flow of the CSF you can see here. So the CSF is actually produced in something called the choroid, CHOROID plexus, and each ventricle has them. So your lateral ventricles, your third and your fourth ventricle all have them. And that's what actually causes the production of CSF. So it initiates in the choroid plexus and the lateral ventricles up here, and then it goes through the interventricular foramen here, just another opening. Then you have, it goes into your third ventricle, and then the CSF builds up more in this third ventricle, flows through the cerebral aqueduct or the aqueduct of Sylvis as it's already known as, goes into the fourth ventricle down here, builds up a little bit more CSF in here through the choroid plexus in the fourth ventricle, and then through another opening it's going to go through down to the subarachnoid spaces, so you'll see it kind of going around the cerebral column up through here. We're in the subarachnoid space still, and then through these things called the arachnoid villi and the arachnoid space. This is how the CSF gets into the venous system and gets carried through the venous blood. And then this arachnoid villi actually will absorb, if there's any extra CSF, it tends to absorb in this area, but goes subarachnoid to arachnoid to the venous blood system. And then you can see here in this graph, it goes to the heart and lungs, through the arterial blood system, and then the arterial blood feeds into the different ventricles. All right, and that's how it flows. You don't have to know that specifically, all the foramens and all those things. However, know starts in the lateral ventricles, goes to the third ventricle through the cerebral aqueduct or aqueduct of Sylvis, through the fourth ventricle to the subarachnoid space, and then it goes to the arachnoid space of the venous system. All right, it's just good to know the flow because I'm about to tell you about two different types of hydrocephalus, and knowing this will help you understand that. Okay, so there are two types of hydrocephalus. All right, there's non-obstructive or communicating hydrocephalus. So this means in this type of hydrocephalus, there's just an impaired absorption of CSF somewhere. Typically, it occurs somewhere where the CSF is leaving the ventricles and then goes into the subarachnoid space. So as it leaves that fourth ventricle and goes into the subarachnoid space, when it's in this area, somehow it's not absorbing as it should. And you saw where those arachnoid villi kind of help with the absorption as well. It's whatever is keeping it from absorbing after it leaves the ventricles. All right, there's not really a rhyme or reason to it per se. It's not the most common, but it happens after it leaves the ventricles. So that's non-obstructive communicating. And it's communicating because the ventricles are still able to communicate with each other as the CSF flows through. It just occurs with absorption after it leaves the ventricles. With the obstructive or non-communicating hydrocephalus, this is actually the most common. And this means that the ventricles are not communicating. So there's an obstruction somewhere in the ventricles itself. Typically, the most common area is between a third and fourth ventricle. Remember that aqueduct of Sylvis that goes from the third ventricle to the fourth ventricle? This is where the obstruction commonly occurs. Not always, but it's common. And most of the cases could be from some kind of developmental malformation there or a defect, or if there was a trauma or brain tumor in that area. As far as signs and symptoms that you will see in hydrocephalus, early signs and symptoms will be abnormally rapid head growth, and you'll see these mainly in infants or up to 2 years of age or more. Because once those fontanelles are closed by 18 months, then you won't see the bulging fontanelles at first. But the head growth typically occurs most up to 1 year, but you're still going to look at it potentially to up to 3 years. But that first year is most important. So if you're seeing that they have abnormal rapid head growth, which you would take by head circumference, is how you're measuring that. Bulging fontanelles, we know. Posterior, when does that close? Anterior, when does that close by? Remember that. Dilated scalp veins, because the pressure on the head is so great. You'll see that the veins are actually popping on their scalp. Separated sutures, so remember those sutures that go in the middle of the head, on the side, and the back. If they're separated and you're able to feel a separation when you shouldn't, then that's a problem. Later signs and symptoms that you may see are frontal enlargement, meaning the front of where the forehead is, it'll be enlarged. It kind of bulges out a little bit. Depressed eyes, and that's because the head's growing so much faster than the eyes. The eyes actually are smaller and kind of sink back in. And the setting sun sign, which we previously went over earlier last week. And then sluggish pupil reaction, because there's so much pressure on the brain, they're not going to be able to react as quickly. Something you may see, general signs and symptoms will be lethargy, very, very irritable, and then they cry when they're picked up or rocked, but quiet when they lie still. So if you think about it, the ICP's intracranial pressure is going to be normalized when the child's lying down. But if you pick them up abruptly, normally the ICP will be able to automatically adjust itself to the change. But when you have hydrocephalus and the CSF is being blocked, you have an increased amount of CSF, increased amount of ICPs, then that ICP is not going to be able to adjust when you pick them up or rock them. So it's going to cause a lot of pain and they're going to cry. So if you see when a kid's laying down and they cry every time they're picked up or rocked because the ICP is going up and down, it's affecting their level, the level in their brain as far as the pressure, then that's a big issue. Another thing you may see in older children is that they may have a headache when they wake up in the morning. As far as surgical interventions and management of hydrocephalus, as I stated before, many of the obstructions occur between the third and fourth ventricle. So they'll remove the obstruction, such as a tumor, they will remove the tumor. They may also do a third ventriculostomy, and what this is in the third ventricle, they'll actually put a little hole in the floor of that third ventricle. And when you put a hole into the third ventricle, it actually drains the CSF back into the CSF flow. All right, so it's going to actually bypass the fourth ventricle and go drain into that compartment under the third ventricle. So if there's obstruction between the third and fourth ventricle, they may do a third ventriculostomy, especially if they can't remove the obstruction, and that will allow the CSF to go from the third ventricle back into the flow of CSF, so it never goes to the fourth ventricle. And then lastly, you may see shunt placement, which we kind of touched base on, but I'm going to show you some pictures in a second. You'll see a VP shunt, a ventriculoperitoneal shunt, and that's when it goes from the ventricle down to the peritoneum, and that's actually the most common. And then you'll see a VA shunt, which is a ventriculo-aortic. So it goes from the ventricle to the aorta of the body. And a lot of times these are revised as a child grows because the shunt tubing will actually shorten because the body's growing. So you have to make sure you're keeping track of that. And so what happens on the shunt is that they have a valve for the CSF in the area of the CSF. So in the ventricle where the top of the shunt is placed, there's a valve and there's a predetermined pressure on that valve. So as it hits that pressure goes higher, the valve will actually open, allows the CSF to drain into the tubing, which is either going into the peritoneum or the aorta. And once it hits the pressure that it wants it to be at, the valve will close. All right, and so it just stays shut until the ICP pressure gets up to the predetermined pressure. It needs to open, and then it opens back up, drains, and closes. All right, so then that's going to drain to be reabsorbed in the peritoneum or the aorta. All right, so I'm going to show you a picture here. Okay, so you can see here on the left you have your VP shunt. It goes into the ventricle. Typically the lateral ventricles is where you'll see. And it's literally this little tubing that goes all the way down to the peritoneum. If the child's really thin, you will actually see this tubing in their neck. And up here, there's a little area where you can take CSF fluid samples. You see this VA shunt has a better little show example for you right here. But right here, they can actually tap into this and get a specimen of the CSF. So in thin children, you'll see the tubing, and you'll typically be able to feel that little area where they can tap for CSF very easily. And you very well be able to palpate it in most children, but in thinner children, you'll be able to see it, palpate it for sure. And then here's your VA shunt, goes from the ventricle down into the aorta. Okay. As far as things you want to be aware of with surgical intervention is infection. Infection is going to be the most serious post placement of a shunt or typically a shunt or any surgery, but if they're having a shunt, they're going to live with it for a very long time. So they want to watch for infection, and they're at greatest risk 1 to 2 months after they put the shunt in. Another issue can be a malfunction or a blockage. So as far as malfunction can occur, there could be a kinking or separation of the tubing from the shunt or in the shunt. There could be some matter that gets into the ventricles and then blocks the actual tubing. So when the valve opens, a little bit of matter gets in there. It's too big for the tubing, so then it blocks the shunt. And then a thrombosis on the distal end of the shunt. So if there's a thrombosis in the aorta or in the peritoneum that's blocking the end of the shunt for it to drain, that can be a problem. And then, as I said before, displacement of the shunt as a result from growing. So if they're having a malfunction or blockage of the shunt, they're going to have all the signs and symptoms that they had for hydrocephalus. So signs of increase in cranial ICPs, all that stuff, very lethargic, irritable, all those signs and symptoms I went back over a few slides back, those are going to come to light after the shunt is placed, which is not normal. They should not have any of those signs and symptoms after the shunt is placed. So if they need a shunt revision, they may need to have a temporary EVD, which we've already discussed in class. Remember, it goes external ventricular drain from the ventricle to the outside of the body to be drained. And you're going to have that tubing to drain it. The bolt is the one that measures ICPs only. The EVD drains and measures ICPs. Okay, so they may need a temporary EVD, especially if there's an infection. Take some antibiotics, let the infection go away, then they'll get a new shunt placed and then they'll keep them and watch them for a couple of days and send them home to make sure everything's cool there. As far as what you can do for a pre-op standpoint, you want to assess for signs of increased ICP, which a lot of them are going to have anyway, but if they're having further complications, you just want to make sure you are notifying the physician appropriately. If surgery is anticipated, do not place scalp IVs for the obvious reasons. They are doing a brain procedure, so you do not want a scalp IV in that place. You want them in other areas. Also, post-op, you want to keep flat post-op to keep the CSF from being removed too rapidly. So especially if this is their first shunt, you want to make sure that they're flat because their body has adjusted to that increased ICP all the time. So they're used to having all that CSF, that increased ICP. Just like if you have hypertension and a heart defect, you got to watch out because you may have rebound hypertension, or the body will continue to have hypertension because it's adjusted to that. That's its normal. So when you're putting a shunt in, you want to keep them flat post-op to keep the CSF from draining too rapidly. They're going to potentially monitor their ICPs afterwards, but more than likely they won't. But if they're having ICP problems in the OR, they may ask you to elevate the bed a little bit just to kind of help decrease the pressure on the brain. Otherwise, you're going to keep the bed flat post-op to keep the CSF from draining too rapidly, and then you'll slowly move them up as time goes on so the body can adjust, opening that valve, draining through the shunt, and just being able to adjust to that. And then pain management if they have any pain, and then doing a neuro assessments. Those are vital. So make sure that you're doing neuro assessments, that they're not having any post-op complications, and they're responding well to the new shunt being placed. Or, of course, if they had a brain tumor removed as well, you want to make sure you're doing neuro assessments. So, next we have craniosynostosis, and this is the premature closure of the cranial sutures. Let me try and switch my little pointer here. Okay, that's better. On the left side, you can see this is a normal baby. These sutures are open right now as they should be. However, this baby on the right-hand side had premature closure of these sutures here, and this is the head shape that they have. So they're going to have an abnormally shaped head, and it depends on what sutures are closing at what time or will have closed prematurely. So typically, if this were to close early up here in front, you'd see more of a bulge in the front area here. But remember, typical closure, 8 weeks or by 2 months, that posterior fontanelle is closed. 6 months, this is when you'll start to see that the suture lines are beginning to interlock their serrated edges and come together, which is normal. By 6 months, they'll start to come together, these sutures are. All right. And then by 18 months, we know what closes. This anterior fontanelle will close. Those are the typical closures. As far as treatment for this, they'll have surgery that will happen typically before 1 year of age, since the bones are most pliable then. Or they may have a molding helmet like this little babe has in this picture. And this will help reshape the skull, and it actually allows for natural growth of the skull while inhibiting growth in the areas that are very prominent, and then allowing growth in the flat regions. All right, so they'll adjust it as a child grows. So say this child had a helmet on, it's going to allow for normal growth in the areas that have not been affected, but not allow those areas that were affected to grow any larger. Hopefully that makes sense. And then as the child grows, they'll change out the helmet to a different size. Okay, next we have plagiocephaly, and this is an asymmetrical head shape. This is typically caused by, unfortunately, laying supine for too long periods of time. That's why babies should not just be left to lay on their back all times. Not to mention they can't develop that neck strength that they need. But as you can see here, here's a normal skull here. We have mild plagiocephaly, moderate plagiocephaly, and then very severe plagiocephaly here. The problem is that it could lead to torticollis, which is a tightening of the sternocleidomastoid muscle, right there in the neck. And then they could also brain development problems. So if you think about how soft the baby's head is and how pliable their skull is, if they're laid flat all the time and their brain's not able to, I mean, a normal brain's not going to be able to grow normally in a skull like this or even like this, but definitely these are terrible. So that's some issues that you can see from not getting it fixed. So encourage parents to put the child on tummy time. Do not just leave them flat all the time, on their back. Even if they're sitting up in something, they're still laying on their head. So make sure that they get that pressure off that head and encourage them to do that tummy time and repositioning. And then the treatment for this is going to be the molding helmet. And typically it's recommended about 6 to 7 months of age for those moderate to severe cases. A mild case can probably fix itself with frequent repositioning since it's pretty early on, but these two cases would definitely need molding helmets. Okay, next is the Arnold-Chiari malformation, and this is actually the downward displacement of the cerebellum. So it's kind of like a little herniated cerebellum. You know how we talked about brain herniation? Um, this is what that is, but you can actually be born with it. So here's your normal cerebellum. You got your CSF space here. On this side, this is Chiari malformation, type 1. So you can see this is a herniated cerebellum. Um, the cerebellum, as you know, is a part of the brain that controls balance. So typical symptoms, if they have any, are going to be a headache, neck pain, problems with balance and coordination are big. They may be extremely spastic in their extremities. Hydrocephalus may be an issue depending on what type they have. Excuse me. And then other symptoms may be different depending on the type because there's 4 different types, but type 1 that you see in this picture here is actually the most common. And we'll talk about interventions in a second, but surgical intervention may be required to relieve the pressure on the brain and spinal cord. That's going to be a more serious Chiari malformation. However, a lot of them are left and just monitored to see if they continue to have an issue and the Chiari malformation is growing and causing more of a problem. Then they'll do a surgical intervention. But since it's such a sensitive place, they really don't want to go in there and do surgery unless they absolutely have to. So if they do decide to do surgical treatment, what that will do is reestablish the normal fluid circulation through and around the area, so the normal CSF circulation. So like I said, type 1, a lot of times they will not do surgical intervention. They'll have more of a just treat the symptoms. So I had a kid in not in nursing school, but as a school nurse who had the type 1 Chiari malformation, and I just had Motrin on hand. So if he came in and complained of a headache, then I would give him the Motrin and just let him be. But if he started to have other symptoms, then I was to notify his mom. She would come pick him up, and then they would take him to the doctor. It's very interesting. You may see this more often than. Next, we have Rye or Ray syndrome, however you would like to pronounce it. And we kind of talked about this previously, but just to kind of touch on it again, it's a toxic encephalopathy characterized by fever, profoundly impaired consciousness, and disordered hepatic function. We know the biggest risk for this, of getting this and cause, is any salicylate or drugs with salicylate in it. So do not give aspirin, which is number one most commonly people know about. The Pepto-Bismol is another one that has a salicylate in it with any viral illness. So salicylates is what you want to watch for. And they don't want to give those to kids, especially if they have a viral illness. It primarily affects the liver and the brain. As far as liver dysfunction, you're going to see bleeding and poor clotting. The reasons behind that, they aren't really sure, but they did find that there is a correlation with Rye syndrome and liver dysfunction. So again, you'll see bleeding and poor clotting. And then cerebral edema, so they'll have increased ICPs because again, it's an encephalopathy. And they could be very lethargic to going to a coma. And because they have increased ICPs, as we've learned previously, they are at risk for herniation. So you want to monitor them closely and do neuro checks and all those wonderful things. So as we just said, you want to make sure you're completing your neuro assessments on them, maintain hydration either through, more than likely you're going to have them on IV fluids. Make sure you have accurate I's and O's with them so you're making sure that you're replacing everything at least 1 to 1. More than likely it'll be 2 to 1, just depending on the order. Monitor coagulation labs because remember, you're looking for those clotting factors, checking for your PT, PTT, all those things to see how their bleeding is. Pain management, more than likely you're not going to give them acetaminophen, Tylenol because the liver is impacted. So you'd give them a Motrin or something of that nature unless something stronger was ordered, but definitely want to avoid acetaminophen for them. Client education, you want to teach parents to avoid salicylates for pain or fever in kids, so no aspirin or avoid that Pepto-Bismol. Read labels to check for over-the-counter meds for having salicylates. It could be in something that they wouldn't expect. A lot of drug companies are removing it from their medications because they know it is a big issue, but they still need to check for it and be sure that they're monitoring for that. And then just providing the family support. Next is bacterial meningitis. So here I just want to put in a slide of the meninges so you guys are aware of where they are. They are the membrane covering the brain and the spinal cord, and it consists of 3 membranes. All right, so you have the dura mater, there's 2 layers of that, the arachnoid mater, and the pia mater. And this is where your meninges are located. So when you have bacterial meningitis, these are the areas that are affected. Okay, so bacterial meningitis is the acute inflammation of the meninges and the cerebral spinal fluid. As far as the bacteria that causes this is like the Hib bacteria or pneumococcal bacteria that will be the culprit of the bacterial meningitis. So vaccinations prevent this. So which ones do you think prevent this? The ones that prevent from that bacteria. So your Hib vaccine and your PCV, which is the pneumococcal conjugate vaccine, are what they need. And they get their first dose at 2 months old, and then they get it again at 4 and 6. So the Hib and pneumococcal or PCV vaccines, they need to be getting those 2, 4, and 6 months. All right. So their brain becomes very edematous, and it actually is covered with exudate. So remember those areas that were affected, where the meninges are, there's exudate in there. It's really bad. In a baby, what you'll typically see symptom-wise, you'll have poor feeding, fontanelles that are bulging, vomiting, a high-pitched cry, all those things that may be symptoms of an increased ICPs. What you'll typically see anywhere from 2 years old to an adolescent will be your irritability, fever, chills, headache, vomiting, nuchal rigidity. Remember that really hurts when they're trying to turn their head from side to side. The Koenig sign will be positive. I had a video for this, and I can post those on Moodle as well because I don't think I can play this while I'm recording this for you and for you to be able to hear it. But those are linked in the PowerPoint. Actually, all you gotta do is click on your PowerPoint because I gave you the PowerPoint and not the PDF. So if you go to this PowerPoint slide and click on those links, it'll show you the test and what's a positive sign. So in 2 years old to adolescents, you'll typically see a positive Koenig sign. So when the hip and knee is flexed to a right angle, and then they slowly extend the knee out. If the patient starts to resist or have pain as the leg's going back out, that's a positive sign. And then the Brudzinski sign, flexion of the neck will elicit pain. And then as the lower extremities are flexed, that will cause pain as well, and that's a positive sign. Then you'll typically see petechial or purpuric rashes, which is what you see here. This is exactly what they look like. I've taken care of a couple of these in the PICU, and notably, this is what the rash looks like. Can be anywhere on the extremities. Mine, kids that I had were on the chest. It's still an issue. The cases are dropping according to the CDC, but there's still about 4,000 cases of this a year, and about 500 of those are dying, which, and this should be preventable because it's all preventable with vaccines. So vaccinations are huge. Diagnostics for bacterial meningitis, they're going to do an LP, nursing intervention. That's what the NI is. What you can do, you will apply EMLA cream to the area. So wherever they're going to be doing the LP, the doctor will show you, which is going to be typically in the same area. You'll put EMLA cream, cover it up. That way it numbs the skin for the insertion of the needle. You'll place the child in a slide-lying position when it's time with the head flexed and the knees drawn to the chest. And you're going to have to hold that baby tight, that kid tight. It may take a couple of people. You can try and distract them. A lot of times they're so out of it, they don't need to be distracted. They're just miserable. But if you have to, distraction, you can try and do that. But we all know how effective that would be. But really holding them in that head flex and knees drawn to chest position is important. After they do the LP, you want to monitor the site for bleeding, any type of development of a hematoma or signs of infection to that area. Obviously, we don't want any type of infection getting to the CSF because it's already infected with bacterial meningitis, so we don't need any other complications. The patient must also lie in a flat position for at least an hour and then watch for a headache. So if they have a headache after their LP, most of the time that's going to be a spinal headache where the spinal fluid is actually leaking out of the spinal column, and it causes a headache because it's draining extra CSF off. So if the cerebral spinal fluid is leaking out of a hole it shouldn't have, then it's going to have less cerebral spinal fluid in the body, and it's going to cause a headache. So what they may do is go in and put a blood patch in, where they just go and put a little patch of blood that actually coagulates the area that's open, and then they lie flat, or they may have them just lie flat for 12 hours to see if the body can resolve the leak itself. Either way, it's miserable. So if they get that headache, try to respond to it quickly. IV antibiotics is what they'll get for treatment. You're going to monitor for signs of increased ICPs. Infants, what are you going to be looking for? You're going to be checking those fontanelles, pupillary reflex, also head circumference will tell you a lot as well. That's more of a long-term thing, but those bulging fontanelles are going to be your number one, along with those other signs of increased ICP with irritability, poor feeding. They're not going to be wanting to eat anyway. Just monitor for signs of ICPs. And then in kids, the same thing. Adolescents, I mean. They're going to be on isolation for 24 hours after starting antibiotics. What kind of isolation do you think they would be on? It's going to be droplets. They'll be on droplet isolation for at least 24 hours. Typically, they'll leave them on there longer for that, just as preventative, just to make sure. They'll be on seizure precautions because, of course, if you have your brain is affected and ICPs are affected, you're at risk for seizures. So they'll be on seizure precautions. And then they will treat close contacts. So anybody who's been in contact with this child, they'll be treated as a preventative to make sure they don't get it as well. Okay, so just a quick question. Neurological assessment. When you assessed your patient at 0800, his pupils looked like this. You go in to reassess at 0900 and his pupils look like this. Are you concerned? And hopefully you would say, oh my gosh, yes, I would be getting help immediately. All right, so they can be acting actually semi-normal with this and still have this dilated pupil, reactive pupil, non-reactive. But if you see this, this is a problem. All right. So the next area, this is about 11 slides long. This is going to be the neuromuscular dysfunction piece. And the first thing we're going to talk about is cerebral palsy. And cerebral palsy is just the name given to a group of conditions that affect motor development in kids and children. Okay, it is the most common permanent physical disability of childhood. It's about 2.4 to 3.6 per every 1,000 kids. It can be anywhere from mild to severe. Why does this occur? It can occur due to any type of gross malformation of the brain, vascular occlusion somewhere, atrophy, loss of neurons, the sulci in the brain if they're too spaced out, or if they have a low brain weight due to a genetic abnormality or some issue there. And then anoxia actually plays the biggest role. So you could have a perfectly healthy baby and then the cord's wrapped around the neck, and if they have an hypoxic injury, then that can lead to CP, and you'll see that a lot. Actually, majority of the kids are probably taken care of. That's what happened. They had a anoxic injury at birth, and then they developed CP. But other reasons can apply as well. There are 4 classifications of CP. You have your spastic, which is your most common. You'll see exaggerated stretch reflexes, ankle clonus, so their ankle will shake back and forth or up and down. It can't be still, it's just clonus. And then eventual development of contractures. All right, because they can't extend all the way out, so they're going to be holding those, particularly their arms, are going to be closer into the body, and if they don't try and stretch those or work with the CP patients to try to get treatment to help extend those tendons and reflexes out, then they're going to have contractures. There's also dyskinetic or non-spastic CP. They have slow twisting movements of the trunk, abnormal posture. Typically, they'll have the involvement of the pharyngeal, laryngeal, oral muscles, so you'll see drooling or imperfect speech articulation. Ataxic is another non-spastic type of CP, and this is a wide-based gait, poorly performed movements that are typically rapid and repetitive, and then mixed is a combo of spastic and dyskinetic. So not only do they have these issues, they'll have these other issues as well. Therapeutic management, they will do a developmental screening to provide an early detection for CP. Therapy will actually, like physical therapy, will promote optimal development, help them attain some type of normalization and their full potential within limits. So whatever their potential is, hopefully physical therapy, occupational therapy, those types of things can help them reach their full potential, but sometimes there may be limitations depending on the type. Spasticity, as far as treatment for that, you'll see that they'll be on a baclofen pump a lot of times, or they may have Valium. Both of them are antispasmodics. So they may either have a pump, like literally it's an actual pump that they wear, baclofen for antispasmodic, or they'll get doses of Valium to help with any spasms. A lot of children also receive Botox to reduce spasticity in targeted muscles. I've seen a lot of kids at Showa who go in for this. They get it put in the tendons, especially in their feet, because they'll develop that like foot drop and unable to walk flat-footed. So they'll get the Botox there, and the Botox actually releases acetylcholine into whatever muscle group it's going to, muscle tendon area, and it will prevent muscle movement. So when the muscle can't move, you can actually start stretching that area out. And then when you're stretching it, once it relaxes, it'll actually help release that muscle group and that tendon area to allow for the patient to hopefully ambulate as they get older with maybe some type of assistance like a walker or ankle foot orthosis and AFO. So it'll actually, while it's paralyzed, you can stretch it out, and then it relaxes that area as well. Hopefully that makes sense. If it doesn't, just let me know. As far as nursing management, you want to educate parents on frequent rest periods when they perform their ADLs. They spend a lot of energy doing their ADLs, so it's important that they do take rest periods while they're doing them. Adequate nutrition. They may end up getting a G-tube, so they may need G-tube feeds or supplemental nutrition in some way. They may have a problem with oral feeding due to the compromised jaw control, especially if they have that dyskinetic CP. So you want to teach the parents how to provide stability for the child with manual jaw control. So here is the manual jaw control. Um, so she's helping to hold it, stabilize it, allowing the child to take something to eat, and then you help stabilize the head while they swallow. Safety, may need to wear protective helmets in the event that they fall. Make sure the parents know that they may need to make changes in the home to keep them safe if they do fall. Have them ride in the car facing backwards as long as possible, since they will have that poor head, neck, and trunk control for a much longer period of time than you would see in a smaller, a normal infant without CP. So they really need to make sure they're facing backwards and having that protection in the car. And then tell parents about the early intervention programs. They're called EIPs, and these are in the school systems, and it serves students who are at risk of not reaching or maintaining academic grade levels, based on their age. And so it provides additional resources to students who need it to reach the grade level performance in the shortest times possible. So EIPs are very common among students with disabilities. Okay, so the next section we have is on neural tube defects, and this is incomplete closure of the neural tube and or vertebrae depending on which defect they have. Neural tube development occurs around 4 weeks of gestation, so if there's a defect, then this is when it's going to happen. Folic acid in pregnancy is what prevents this from happening, so it's incredibly important during pregnancy for moms to be on this, particularly even before they get pregnant is best. Diagnostics, prenatal detection will occur around 16 to 18 weeks, which is going to be the optimal time to find these defects, and it can occur via ultrasound or an amniocentesis. First, we'll talk about spina bifida, and you have occulta versus cystica. Okay, so occulta defects are not visible externally. All right, so here's your normal right here, neural column. Here is spina bifida occulta. So you see that you're missing some vertebrae. There's some issue here, but it's not protruding outside of the skin. It's internal. Okay, there's no external defect. Cystica, there is a visible defect with external sac-like protrusion. And these are going to be where you see your meningocele and your myomeningocele, which we'll talk about in a second, the differences. So occulta, remember, it's not visible externally. Cystica, there is an external sac-like protrusion, and that's your meningocele or your myomeningocele. And your symptoms will vary depending on the location of the lesion on the spinal column. So it depends on where on the spinal column it occurred. Okay, so first we'll talk about the meningocele, and this is a hernial protrusion of a sac-like cyst of meninges filled with spinal fluid. So no neural elements. All right, so there's no neurological deficit associated with meningocele. All right, so you can see here, this is the sac-like cyst protrusion, and this has both meninges and spinal fluid. Because if you remember, the pia mater, dura mater, arachnoid mater, all that actually goes down the spinal column. So meninges, that is affected. Meninges can be affected in the spinal column as well. All right, so no neural elements, just meninges filled with spinal fluid and the sac-like cyst. So there's no deficit neurological. So next, we have our myelomeningocele. I think I actually left this L off the other slides, but it's myelomeningocele, not myomeningocele. And if you think about it, a meningocele is your meninges and spinal fluid, right? So myelomeningocele, you're adding to your meningocele. So you have everything a meningocele has, but you also have a portion of the spinal cord with its nerves. So see, this is normal right here. And then the myelomeningocele, you have your spinal cord and nerves coming out here. It's not good. And so there's varying degrees of neurological deficit depending on how severe it is. This is real life baby with it right here. Typically, when people say spina bifida, they're referring to a myelomeningocele, but just know that it doesn't have to be just a myelomeningocele. It can be a meningocele too. Um, Something you want to know, if this sac ruptures, then there is a significant risk for CNS infection. So if this sac ever ruptures, physician needs to be contacted immediately. So you want to keep it moist. You'll typically keep it covered with a wet gauze, and you're very mindful of this area. Very, very. So, as far as management, pre-op care, you're like I kind of just said, you want to keep that sac protected, and you cover it with a wet, sterile dressing or gauze, and you're going to keep them prone because obviously you cannot place them on supine because they're going to put pressure on that sac. So, if the external sac is present, which would be your cystica, spina bifida. Remember, occulta's inside, cystica, which is your meningocele, myelomeningocele, that's going to be outside. Notice the cyst and cystica. You're also going to, for post-op, again, you're still going to keep them prone and you're going to keep the surgical site clean and dry. You want to make sure that they are urinating. If they aren't, they may need catheterization, and they may do catheterization, self-cast for the rest of their life. It just depends on what was affected. They're at high risk for hydrocephalus because the flow of CSF is so impacted. So you may see that they will have a VP shunt placed. Again, you could see a VA shunt, but VP shunt is the most common. And then as far as long-term issues, severity will vary depending on where it occurred and how severe it was. But typically, they may need a wheelchair for mobility or some type of walker or even a cane, just depending. And then commonly, they'll need home catheterization. And as teenagers, they're at high risk for depression because of their immobility issues or mobility issues, I should say, and the difference in their gait. A lot of times you can tell by their gait, how they walk, that they had spina bifida or was born with spina bifida. So just be aware of those. Excuse me. Okay, our next area we're going to talk about is spinal muscle atrophy, or you may have heard it as SMA. This is an autosomal recessive defect or disease, I should say. So remember, autosomal recessive is when two parents must carry the gene for SMA. All right, like CF is autosomal recessive. There are three types, types 1 through 3. Type 1, which is Wernicke-Hoffmann disease, is actually the most severe, and it's known as floppy infant syndrome. They're known as the non-sitters. Type 2, you'll see labeled as a sitter, so they can sit up, and then type 3 are walkers. And then as far as how long they live depends on what type they have, but types 1 usually will not survive past 3 to 6 months depending. I actually had a nursing student who had two children that passed away from this, and she had one surviving one that didn't have SMA, but she had two children that had SMA, and both of them passed away. But there is no cure from this. It's really, really sad. You are likely to see this in the hospital. Treatment is going to be for your symptoms and any type of preventative treatment. So preventative would be for contractures or orthopedic issues such as scoliosis. So you can put them in AFOs, ankle foot orthosis, to kind of help with contractures. Make sure they're doing lots of stretching. Pressure ulcer is also an issue, so rotating how they're sitting and laying, particularly for those who are type 1 or type 2. And then symptoms would just be any pain, any other issues they may have. They may be end up being on like a BiPAP machine at home, because when they sleep, they're going to obstruct, because they don't have, you think of it, they're losing all their skeletal muscle abilities. So with SMA, they actually have degeneration of the anterior horn cells, and that is what controls your skeletal muscles. So they're going to have progressive weakness and wasting of the skeletal muscles. So that's what caused them to be so floppy. And this occurs with, swallowing. I mean, any type of skeletal muscle you can think of. So they may be on a BiPAP machine at home to keep them from obstructing while they sleep. And then nutrition, they usually have a G tube, so you would just teach them about that. Okay, and last but not least, we have Duchenne muscular dystrophy, and it's actually the most common and severe muscular dystrophy in children. It's actually an X-linked recessive disease, so it's going to affect males pretty much exclusively because girls are XX, boys are XY. So a girl has to get an X from both the father and the mother. So they're either going to be unaffected or the daughter will get the X from the mom that is affected, so she'll just be a carrier. So the son can either be unaffected or affected. They're not going to be carriers. But males won't be carriers. They'll either be affected or unaffected. If you're confused by that, let me know. But it's X linked. All right, so the son has to get the Y from the dad and the X from the mom. So their risk of actually getting this X linked is going to be much greater. I mean, they're the only ones that can be affected. But anyway, you're going to see degenerative muscle loss, usually present at 3 to 5 years of age. They're going to have decrease in development, meaning that they're not going to develop as quickly or as normally as they should. So you'll see that they'll have difficulty with balance or gross motor skills. So think about muscular dystrophy. Your muscles are not working correctly. Gower's sign. Again, come to this slide in your PowerPoint, click on that illustration link, and I'll give you a video of a Gower sign. I have it on this next slide, but this will give you a better visualization of it. Diagnostics, they'll do a muscle biopsy to check and see if there's any issues there. You may also see that they'll have an EMG or an electromyography, and this actually is going to test the health of the muscles and the nerve cells that control them. So it looks at the motor neurons rather than just the muscle itself. And then they're going to draw a serum CK level. And remember that this actually will be used to detect if there's any muscle inflammation or if you have any muscle damage to obviously the muscles. So you'll see that CK levels are drawn in MIs or heart attack problems. Somebody has a heart attack, they'll draw a CK, but they also will do it to see if there's any kind of muscle damage from any other disorders like DMD, and see what the level is on that. Treatments may be steroids. They have found that corticosteroids actually help people with DMD to improve their strength and function and actually help them continue their ability to walk, because as time goes on they start to lose that ability to walk. PT and special braces on their legs and arms will help as well. And this is just the last slide, known as the Gower sign. This is what I was talking about. So they're on the floor. In order for them to get up, they get on their hands and knees. Then they start to walk their hands back to help push their legs. So they stand up on their legs using their arms, and they walk their hands back, put their hands on their knees, and then walk themselves up their body to stand up. And that's the Gower sign. But again, go back to that previous slide, click on illustration, and that will give you better visual for that. Okay? Let me know if you have any questions.